everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. In this episode of the podcast, it gives me great pleasure to have as our guest Dr. Pamela Hess. Dr. Hess holds a doctorate in occupational therapy and is a clinical assistant professor at the University of Florida College of Public Health and Health Professions in the Department of Occupational Therapy. She also has a joint appointment in the Department of Surgery and holds a Bachelor of Science in Healthcare Administration. Her clinical background includes inpatient acute care pelvic health and women's health. She is currently developing programmatic initiatives to support surgeons' well-being in and out of the operating room. So, hello, Pam, and welcome to the Surgical Ergonomics podcast.
Thank you, Geeta. It's such a privilege and honor, honestly, to be here and especially to have this conversation with you, which is very close to my heart as well.
Agreed. So without further ado, let's get going. So Pam, please tell our listeners a little bit about yourself, including where you grew up, your training, and how you came to find yourself in Florida.
Yeah, so honestly, I grew up all over the country. My dad was in the military, so was always, I guess, at that moment in my life, I kind of learned to adapt to all different types of climates and environments quickly. We moved from Mississippi to Alaska to England, all over the country, and the world. With that said, though, I ended up in Gainesville, Florida in 1992 and actually lived here and went to college, worked, and then met my husband here in 95 is when I started dating my husband, Dr. Philip Hess, who actually is on faculty here. He's a heart surgeon himself, but he was in his residency at the time that he and I met, and we got married in 1999, getting ready to celebrate our 26th anniversary tomorrow. And but we, I've lived the life of, I guess, in a sense of kind of a surgical life through the lens of him. But we lived here until 2015, and then we moved to Indiana. And that is where I actually went on to my graduate schooling of occupational therapy. I knew I wanted to get back into school and have get a sort of a higher educated degree. And OT really resonated with me for lots of reasons. One of the reasons was the fact that it's very holistic and it really looks at the person as a whole person. And then, of course, from a personal perspective, our son actually had some OT when he was little. So I really felt drawn to this profession. And then through that, I had the opportunity to obviously work with the Department of Surgery there at IU Health and the Department of Surgery with IU College of Medicine for my own personal research and capstone project. But then we ended up moving back to Florida, Gainesville, Florida, last year. So in 2024, we decided to relocate again, and here we are. And I've kind of taken the dual hat as well in regards to my professional life. I am now with the OT department here at UF on faculty, and then I'm also having a joint appointment, like you said, with the Department of Surgery here to help kind of cultivate and build a nice wellbeing and ergonomics program for them. So I'm already involved with several projects and really glad to be back. It's a little warmer, but yet we just had a nice storm. So kind of ironic that I moved from the Midwest back to Florida and it's been cold. So that's kind of been my quick little history of how I came to be here back in Florida.
Oh, that's great. See, I hadn't realized that this was a homecoming for you. So now I've learned something new. And I have to share with our listeners that I am so glad that you chose, occupational therapy when you went to grad school back in Indiana and have made surgical ergonomics one of your areas of interest. So I also want to let our listeners know that you were part of that initial core interest group that we formed in 2020 in the early days of the pandemic, the Surgical Ergonomics Interest Group, then ultimately became the Society of Surgical Ergonomics in late 2021. And in fact, you were one of the initial co-chairs of the Education Committee for some time. So I'm familiar with your story a little bit about how you came to be interested in surgical ergonomics, but I'd like you to share with all of us today and our listeners how you went from being, inpatient acute pelvic health, how that kind of then led to surgical ergonomics and culminated, in both your interests kind of being part of your life now.
Yeah, great question. Well, so here's how it unraveled. So
Sure.
as an OT student, we had to create a graduating, part of our graduation requirements was to have a doctoral capstone project. At first, my project was honestly focused on maternal health. But
Mm,
because of the situation and my mentor at the time, unfortunately, had to step away from that position, I had to quickly shift my focus on some other type of project, which it just kind of it hit me because I keep, my husband is a surgeon. He's actually a heart surgeon. And there's just some things that even our day-to-day lives, I started noticing even with him and how his job was very daunting, not only just physically, but mentally, kind of created this curiosity. I wonder, kind of that I wonder if, I know OTs are we have such a role in ergonomics, but then my question was, well, where are we, is there something for the OR? Is there, how do we manage the surgeons? How does someone help my husband, to be able to have a long career? And so that was where the question came from. And so that's my project came out of that. And I worked with some of the minimally invasive surgeons there at IU. Again, it's more of it's a passion project because I've seen since then some of the things that my husband even does now in his OR as a result of that project that came out of that. And then the other thing is because of this curiosity, I started hearing and getting, the opportunities to have conversations with other surgeons. And then one conversation leads to another. And then all of a sudden I'm having a conversation with you and some of the other folks that kind of are on the founding group of that society. So crazy, but it's such a small world. We talked about that before we came on, but I have a really special place for surgeons. And again, I'm a little biased for sure, but I also have a lot of friends who have been hurt because of poor
yeah.
ergonomics in the operating room. So,
Yeah. Yeah. No,
and
agreed.
in
And
particular, female, that's the other part is that we haven't even talked about the female surgeon and kind of the issues
we're
related to that.
going to. We're going to. Just for our listeners, I mean, I have been waiting to talk to you about this. So, patience is always rewarded. Thank you for sharing your journey with us because as you were telling me about this, that we sort of often see these sayings in social media or, somebody puts up a saying, etc. And you're like, oh, maybe it was meant for me. What came to mind as I was listening to you was one of those things. So I'm so grateful, Pam, that what they say, what doesn't work out for you actually worked out for you. So,
Mhm.
I
Yeah.
realize in the middle of your doctoral thesis, if your supervisor, decides to leave or change course, that's rough as a graduate student. But to our benefit and the surgeons around you and the Society of Surgical Ergonomics, et cetera, it worked to our benefit. So,
Mhm.
coming to that very thing that you indicated. So, as part of your project, you went to the OR. Obviously, I heard you say you observed your husband. That I wish I was a fly on the wall when you did that. But you observed other surgeons, and you actually developed a program, right, at the University of Indiana called the Comprehensive Operating Room Ergonomics. I know you published about it as well.
Yeah.
So,
Mhm.
could you tell us more about this core program and, how it came about and what you found, et cetera?
Yeah. So when I shifted my focus, the chair of Department of Surgery at the time at Indiana University was Dr. Gary Dunnington, and he and I had a conversation kind of off the cuff, essentially at a
Hmm.
casual situation, and just explaining to him, the wellness initiatives with surgeons. And then, of course, one thing led to another. I pitched my idea to the Department of Surgery, and then because of my holistic lens as an OT, it's just not the physical, but it's the emotional, the environmental, and, not only the external environmental aspect, but I also think about the internal environment that we all live in as well, So kind of using that lens as an occupational therapist and understanding kind of how I could mitigate that into the OR, I created this program. And that's why I call it comprehensive, because it's just not about one thing. It's about the
I
whole
see.
person, right? And what's going on in the operating room as much as what's going on outside the OR.
Outside the operating
So I called it core. And of course, I'm a Pilates teacher. So I always think
room.
everything does start in the core. And I thought, well, that's perfect. I love the acronyms. And OTs always talk in acronyms, it seems like. So I decided to develop this program, and it really does touch on just the physical, the emotional, and the environmental, and it's theory based. And we ran a small pilot study that did show a difference, a significant difference in just, at least if anything, the awareness and people making changes. And it was just enough, just to if anything, get some changes made, or at least perhaps help bring some light to what's going on in the operating room, not only just from in the OR, but just organizationally as well. I feel like, because since I've left, I know they're still doing pieces of it and studying it, which I'm really excited to see that the sustainability of it actually is occurring to some degree. So yeah, and
Yeah.
I published it last year in our American Journal of Occupational Therapy. So it's out there and open to even feedback, how can we make it better?
Well, this is fantastic because we're always looking for practical advice that people can take away. So having this reference, people can go take a look at it. But since we've been talking about it, I want to delve into a little bit more. So as you said, this comprehensive operating room ergonomics program included things that you were addressing things in the OR, outside the OR, and also, as you said, emotional and environmental elements for the surgeon.
Mhm.
So for people who don't have time to go and read the study, which is generally our
Yeah.
audience, can
Mhm.
you
Right.
summarize for us what was it that you were looking at, and specifically what the interventions were? And when you said it made a difference, what did it make a difference in?
How I designed it is first, I wanted I used an adaptation of one of our assessment tools that we have in OT. And I wanted it most importantly to make sure that it is very individualized and very what I would call client centered. And that's kind of my approach as an OT. So if anything, I had this moment where I had talked to the surgeons, had this intake, if you will, about their goals. And then I actually did an posture assessment. So, because I think that was a
Okay.
really great way to measure. I mean, granted, it was a short amount of time, and you can't, like, I think over time you could probably see a change in somebody's posture. But for the small pilot study, at least what I did with that measurement and that image was to bring some awareness to those
Mm-hmm.
surgeons, because one of the things that people have absolutely no aware of is their body in
Mm-hmm.
space. So if anything, it made a lot of eyebrows go up when the surgeons saw their posture, and then just in a loving way identified, the variations in their posture, perhaps at the point of this could be related to your job. And, obviously, if there's some asymmetries, especially extreme asymmetries in somebody's posture, it's going to impact their ability to perform various occupational tasks, even just operating room stuff, So that was one piece. And then the after getting that assessment, then it was my opportunity to go in and observe them in the operating room. And I used the RULA, which is a rapid upper limb assessment tool, to help bring some quantitative data into my study, where I would take still pictures, several still pictures, and I would actually measure sort of the worst case postures as the surgeon was showing. After that, showing them those pictures and assessing them. And then what I would actually provide is the intervention was, okay, here's what let's do. Let's think about lowering that monitor so your neck isn't extended, because remember, these are minimally invasive surgeons. And so teaching them proper settings up for their, setting for their monitor and the table
Mhm.
height, and just also increasing their awareness. As I was in the operating room actually observing, I would every once in a while would just coach them up and say, hey, do you realize you're standing this way? Do you realize your shoulders are up by your ears, or whatever? And so those were some of the interventions I actually provided. And then introducing micro breaks, part of that was,
Mhm.
how do we navigate the micro breaks? I think those are brilliant. And I think there's just not enough, trust in the system that you can have these micro breaks without changing or impacting your productivity level, which unfortunately is what drives a lot of surgery in it, as itself. So after the intervention and, taking the assessment, evaluation, intervention, and then I actually reassessed them with the Rula to show any change. And that's where I saw the change. And then the other was the being able to have a moment after them with the surgeons to discuss what did you think about the program. And then also I even asked them questions, some qualitative stuff with regards to any kind of education that they might have had in their surgical training or even in their onboarding of their job. Of course, most of them said no. And that, so
Yeah,
in a nutshell, I mean, that's where most of my
that's
change showed, that was the awareness of what was going on. The Rula score showed definitely that was where I saw the biggest significance. And then, just the feedback and the opportunity. And I would give them exercises, based on
to do
Pilates.
outside the OR. Yeah, to do
Yeah,
outside the OR.
yeah. And the other thing that I did was we talked a lot was about what were they doing outside the operating room? Like, what are some of the things that, in their everyday life? How are you holding your child? Like one of the residents, I mean, not residents, but one of the surgeons was actually, holding her baby on the one hip that she ended up kind of, that pelvis was sort of laterally gliding to that one
Tilted.
side, and which that was, she was doing the same movement in the operating room, like standing on that one leg where her other leg was the bovie leg, is what one of my friends who's a
Yeah.
surgeon calls it. So it's just, and then even just the car, like how are you sitting in your car? What do we,
Hmm.
those kinds of things. So
Yeah.
just trying to talk about like, how do you translate this into the everyday life of yourself
Okay.
as well?
Right. This is all fantastic, Pam. So I want our listeners to realize that the last few minutes that Pam has explained what she did with the surgeons is absolute gold, and what we talk about in the Society of Surgical Ergonomics and what ergonomics coaching is all about for procedural staff, right? Now, Pam talked about coaching surgeons, but this can apply to surgical trainees, it can apply to scrub techs, it can apply to OR nurses, etc. And throughout this podcast series, I'm going to be exploring ergonomics and procedural ergonomics through the lens of various individuals who work in the operating room. So more to come on that. But I just wanted to point out again, the key things that Pam has said, ergonomics for surgeons and procedural staff is not just about what you do in the OR, but it's also what you do outside the OR. And in
Mhm.
the OR, you heard Pam describing sort of best practices, for laparoscopic surgeons, where to keep the monitor, where to have the table height, etc. All these things in detail. You can look at her study, or you can look at the Society of Surgical Ergonomics website. All of these best practices for the different kinds of surgeries that you do, that's important. But even more important is what you do outside the OR, not in just in terms of your hobbies and your day-to-day activities, especially carrying children, carrying groceries, gardening, all of those things. Posture
Mhm.
is important. But then, since Pam comes from a Pilates background, she explained that, she's teaching people to take care of their bodies. We're going to jump into that in just a moment. But I will say again that, people really need to kind of pay attention to this framework, because we as surgeons, honestly, what we're used to doing is writing PT/OT consult. We're not entirely always sure, at least a lot of people I think are not sure what exactly the occupational therapist does. And you've just shown in such a nice capsule what they do, right? For our patients, for everyone, for our listeners, for our patients, for example, occupational therapists who are seeing them as an inpatient would be saying, well, can they do their activities of daily living? How are they going to get from their bed to the bathroom, up from the bathroom commode to back to their bed, etc. So Pam has put her occupational therapy knowledge, know-how, and expertise to looking at the same things as what do surgeons do in their occupation? How do they get from, this part of the surgery to that part of the surgery and come back to the operating room the next day? What's hurting, what she can minimize, right? So there's a lot of lack of knowledge about surgical ergonomics awareness. It's slowly getting better. There are curricula, etc. But you can work at your own institution by finding ergonomists, surgeons who are interested in surgical ergonomics, or occupational therapists like Pam who
Yeah.
are interested in
Mhm.
surgical ergonomics. So I just want you to know that these are some of the resources that you can utilize as you're looking. And Pam, just while we're on this, I think you, just like me, you've translated a lot of this knowledge into actually coaching surgeons, right? You have kind of a side gig like I do. Can you tell
Yeah.
our viewers a little bit about that and maybe how they can reach you if they're interested in
Sure.
exploring some ergonomics coaching with you? And then I want to talk about Surgilates.
I'll make sure you have my contact
Okay.
information, but my personal email is actually a great way to reach me, which
Okay.
we can link that into the show notes here. But I just kind of doing it on the peripheral off hours because I am
Mhm.
full time at the University of Florida and I just want to respect, my role here. But that is definitely something I do. I think it's the nice thing about the technology is you could certainly do a lot virtually. I
Yeah.
had just met with a surgeon this past weekend. So yeah, I'm happy to help and I'm happy to consult and provide. I come from an abundant place. And because it's such a passion of mine, because it's personally a passion of mine, I want to see a change. I think surgeons
Okay.
still deserve way better.
Awesome. Now tell me more and tell us more about this Surgilates. So you said, you're a Pilates instructor, and I think you've adapted Pilates for surgeons because one of the biggest things we need to know is that our bodies is our best instrument. Yes, we use other instruments and
Mhm.
there's work needed to be done to improve kind of the fit of
Mhm.
instruments, but the best thing we can do is take good care of our physical health. And you can do that by yoga, by Pilates, by working out with a trainer, etc. But we know that we need strength and stretching for surgeons, right? We need both components.
Yeah.
So tell me more about Surgilates.
Serialities, I love that. I mean, honestly, it was a term and coined term that came out of
Yeah,
I think a conversation with you and Dr. Krauser up at Michigan and Dr.
I see.
Susan Hellbeck. I mean, I think it was just kind of like one
Yeah.
of those conversations. It's like, oh, I love that. But I'm like, yeah, why don't we do surgeon Pilates, like Pilates for surgeons? But yeah, I have a quick little, I think it's like a 20-ish minute video up on the Society
Hmm.
of Surgical Ergonomics website that I designed for surgeons. And my goal was that is the thing about Pilates, it's very functional. Originally, it was designed as a corrective exercise movement. So it comes from that perspective. And because of an occupational therapist, everything I want to do is make sure it's going to help return to function or maintain function. And so with Pilates, I just think that's like the perfect marriage is to be able to have, some kind of a class or some kind of, movement practice that is going to be very
Hmm.
functional. And Pilates is perfect for that. And the nice thing about this particular class that I designed was it's all about opening up the chest. It's keeping the posture aligned. It's focusing on core muscles. And the thing is people sometimes forget that our core muscles is actually a really deep muscles, and that's including your pelvic
Mm.
floor. And so I use a lot of those terminology. And then, yeah, and just a lot of mobility in regards to our joints. I think there's so much of that kyphosis that we're all trying to avoid. And the nice thing about Pilates is it works the body in all different ranges of motion. And that's the thing about a Pilates class is that you want to make sure that your body is moving in all planes of motion. And surgeons tend to work in only one plane, and so it really allows the surgeon, I think, to help return to function so that they can continue to do their job, but also do the things that they might love outside of the operating room. So it's just it's fun and it's a very functional thing. The nice thing is it is a mat workout, so you can do it anywhere. And I know surgeons are so busy, so I wanted to make it quick and, very accessible to them as well.
Right. Thank you so much for doing that. I know that it's on the SSE website, and I will include the link to it in the show notes just so people, can find it easily. And, yes, we're all very busy and you've made it very easy and accessible. Just a reminder to everyone, though, if you are already hurting or have injuries, check in with your physical therapist or primary care physician before you do any sort of exercises. Okay, so these are, if you don't have injuries and are looking to stretch and strengthen, then you want to look at these general exercises. But if you have injuries, then you need to do some specific things, and best to start with your physical therapist or physician. Now comes the meat of this thing. So, for those of our listeners who don't know, Pam was actually part of a panel at the AWS in 2023 on ergonomics for the female surgeon. And for obvious reasons, her expertise is in women's health, pelvic floor health, and the marriage of that with surgical ergonomics or procedural ergonomics brings me to this. So, Pam, we know from all the work we've seen in the society and continue to see in all the meetings we go to, women surgeons, we know the literature says, and we know this from experience, that women surgeons are more likely to have work-related MSK symptoms and injuries regardless of specialty, right? So, from a functional occupational therapist perspective, why is that? And, what have you seen as some of the more unique challenges faced by women surgeons and proceduralists and trainees? And what can they do specifically to mitigate some of these risks?
Mm, gosh, there's I
I know it's a huge topic, but we'll
yeah,
start we'll
yeah,
start
yeah, yeah.
delving into it, and it just means that I have to have you come back at some point to talk specifically about this.
I love this, and there's just so many things, but I do think that one of the things that is very, very profound about this area of ergonomics, especially in surgeons, especially female surgeons, is that the industry is lagging way behind in regards to equipment that are designed for women. I was just talking to one of our female general surgeons last week, and she was describing to me the adaptations that she has tried to figure out on her own and how to use a stapler.
Yeah.
And although and that's the manual one, and then she says, there's just no way I can do it with just one hand. And so she described what she has to do in order to do that. And then she also just said that what it's now done is resorted to the fact that she's using, and correct me because I still, sometimes get a little bit lost in the terminology, but it's like a automatic one, but she still, I
Mm-hmm.
guess, has to struggle because the way to release, there's like a button on top that is still too high for her thumb to get up there to release it. So she drew it out, and I just thinking to myself, why is something as simple as that, right? That really probably would take like honestly a quick little adjustment in the way that they design these equipment, and then also I think how much more efficient these surgeons can be. That's just one example, and then there's those examples of the female surgeon who is pregnant and who
Mm-hmm.
gets pregnant, and then her belly grows and all the stuff that goes along with that, and the adjustments that that person has to make in order to do her job, and the equipment this doesn't really afford that. So I do think we got to get industry on board, and I think that there is some change and some shift that's happening, but I just think I almost feel like the gap it's still pretty far to make a difference. And so I don't know, I just think there are some things that we can do for female surgeons in the time. I think the other part is time away when you have postpartum time away. I think that's changing, and that has changed. I think a lot of women are advocating for their full amount. And then I also think about just the impact that, even women who are even menopausal. I mean, you can even kind of go down that road, right? There's a lot of other things that go along with that. So when hormones shift in our body, the collagen and the elasticity around our joints change, no matter where you're at in the stage of your life. So you're more susceptible to injury with regards to, hand and wrist injuries, shoulder injuries, the low back, pelvic floor. That's a whole nother
Right.
topic. But yeah, I mean, it goes on, and I might as well stop and let you,
Yeah.
you know, it's, help
No,
me
I was going to say,
even more.
yeah, don't stop, because as I'm sitting here listening, I saw sort of two or three different areas, right? That require a little bit of in-depth, and it's okay. We have a little bit more time, and if not, as I said, you've guaranteed now that you have a repeat episode down the road. I'm sure we're gonna get a lot of questions about this, but I'm hoping that we can give, people something to take away with today, even. So you brought up a very good reason why women are at higher risk for MSK injury. The instrumentation is absolutely a huge piece, and we're working with the SSE and the Industry Relations Committee to help have these conversations and see what the barriers are. We as providers think, or as surgeons and occupational therapists and ergonomists think, well, it's just this little button. I mean, if they could just move it. Unfortunately, as we're learning with in discussions with industry, it's a little bit more than that, and where they actually consider the ergonomics, what data they're going by, hand size,
Hmm.
things like that. So the
Hmm.
studies that we're doing in SSE will help with that. But intrinsically, you pointed out there are some physiologic things, right? So for example, we know that estrogen and other hormones in pregnancy, particularly as pregnancy advances, relaxin, etc., all of these
Hmm.
things, as the pelvis prepares for childbirth, all of these things, relaxin is important for that. It means that it's not just going to your pelvis, it's going to all your joints and ligaments. So you're going to be more prone to injury with laparoscopy. I've seen some recommendations, nothing by any societies, but just sort of conjecturing and suggestions from various sort of female surgeons and organizations is like, well, perhaps you shouldn't be doing, heavy duty laparoscopy and things, in this beyond the second, third trimester, especially in the third trimester. Not, there are some sort of discussions on how many hours one can stand, not
Right.
doing overnight call. All of those things are coming about. The changes are slow, but they're coming about.
Hmm.
What could advice could you give as an occupational therapist for our pregnant colleagues working in procedural and operating room areas? Like what, for example, should they be taking breaks more often? Are there some specific exercises and stretches that they should be paying attention to? I realize this is a topic into itself,
Yeah.
but maybe just a couple of things.
Yeah, yeah. No, I think that's good. I think some very quick, tangible ones, especially if you're
Yeah.
pregnant or you're even thinking about it, definitely having, like, even though you have like a delivery plan, oftentimes people have like a plan of how they're going to deliver. I think it's important to even sit down and have a conversation with your department chair or your division chair, just to talk about
Mhm.
how can you best support me? So even having that conversation, being transparent is going to be, I think, a really important piece to this, especially from a buy-in
Mhm.
and as you progress along.
Mhm.
Simple things, right? So definitely as you progress in your pregnancy, you're going to be a lot more susceptible to those injuries. And there are a lot of support things that you could do, like certain things, like I call it a belly band that women can wear along their pregnancy. I think that's a really important piece to, especially females who are on their feet a lot, pregnant. So helping support their belly
And back, lower back. Is that kind
and
of like a
lower
back
back.
belt? Yeah.
Yeah, because I mean,
Okay.
it's kind of like a back, but it kind of
Okay.
goes underneath the belly and then
Right.
it kind of wraps around the hips and it just kind of helps really secure. I would call it kind of like a support bra for your
Okay.
pelvis and your belly.
Okay.
And then also I would even consider, what are you making sure that when you're not in the operating room that you're doing things outside, such as making sure you're hydrating yourself. And that's the hard part.
Hmm.
I know with a lot of surgeons, they
Yeah.
just don't drink enough water. And
Yeah.
especially if you're pregnant, you need to make sure you're hydrating. Women don't realize that even if nursing women, right, someone who's had the baby and decided to nurse, you actually need almost 120 ounces of water to be able to sustain your overall health and well-being for
Yeah.
you and your baby. So nutrition, I think, finding ways to sleep, that's another option, is being able to find that
Yeah.
great position and supporting yourself with as many pillows as possible. And
Hmm.
then also like certain exercises that help, keeping that pelvic floor supple. Because, sometimes, especially new moms who have never had a baby, and perhaps their pelvic floor, and a lot of surgeons will end up having really hypertonic pelvic floor because of the
Hmm.
fact that they've been standing and they haven't really engaged it, and your body is just holding on for dear life. But being able, the muscle is only as strong as its ability to lengthen and contract. So being able to make sure that if you have the opportunity to work for the pelvic floor therapist, definitely go do that. I think that would help you and you be able to sustain your pregnancy without, well, minimally as painful as possible. In there can be certain things that making sure that if you're at the desk typing or having that notes, because you're a little bit more susceptible to wrist and hand
Wrist
injuries as a
injuries, yeah.
pregnant. Yeah, is
Hmm.
you're making sure that when you're typing that you actually have your desk and your office kind of set up correctly. And even at the nurse's station, take the time to do that. Compression hose and stockings are good as long as
Hmm.
ideally it'd be nice if you could formally get it fit. So yeah, and then again, setting up your OR so it best suits you, and especially as your belly grows. And that is a
Yeah,
tricky place. So,
yeah. Yeah, unfortunately, the OR tables haven't quite come
mm.
in that cutout configuration. Although I have to say that the newer robotic platform emphasizes that they have done that something like that, which is similar to what, desks that go up and
Yeah,
down, movable desks have that little bit of a cutout. It's not nearly enough, but I'm sure it helps a
yeah.
little bit. So this was all, again, lots of gold for our pregnancy colleagues until our environment changes,
Mhm.
how we can protect ourselves. And I'm going to extend this just a little bit more. I know you brought up the pelvic floor therapist and their key role. Now, this is a physical therapist who specializes in pelvic floor. How can they
Yeah.
help us
Mhm.
us women of a certain age that are beyond their childbearing? What are the
Sure.
challenges that we face then from having stood years and years in the operating room? I mean,
Yeah.
pelvic organ prolapse, is that
Yeah.
higher
Yeah.
among women that stand for long periods of time?
Yes, absolutely. I will say that OTs, pelvic floor OTs, actually they're out there as well. And it's kind of been so
I see.
whoever you decide PT OT, it's your whoever you best. I The thing is we're treating the person, and I will encourage it if you decide to find a pelvic
Yeah.
floor therapist, make sure that it's the right fit for you. So whether it's an OT or a PT. So as we age, and I will say this not only just for females but for male surgeons, they
Okay.
have pelvic floors too, right? So
Yeah.
really being mindful of the symptoms that you might be feeling, a sense of heaviness, low back pain can mean also that you've got some pelvic floor dysfunction. Obviously, the urinary and bowel function is going to be an indicator. So if something changes, such as you're leaking, whether it's urinary incontinence or even fecal incontinence, or you're not having a bowel movement, those are some indicators. And I say that would be a good sign of saying, okay, I'm going to go and I need to go find a pelvic floor therapist. And our hormones, as well as females and males, change as we grow
Yep.
older. So things do change. And
Hmm.
oftentimes just a simple little tweaking of, maybe posture or maybe some exercises or maybe even just new nutrition or in something environmentally has changed. I am a huge advocate of the squatty potty. So if you don't have one of
I
those,
can I
get
can
one.
see that. I can see why that would be, just given what you've said. Okay.
Right.
So,
So I mean, there's a lot of little things that you could be doing to support yourself, even when you're young. It doesn't,
yeah.
don't wait. So yeah.
Right. Right.
I
Right.
will say
Right.
that breathing is a really important piece, and I'm not just saying this to the
Huh.
pregnant population, but even as surgeons, because of the high intensity and environment that you all work in, oftentimes I find a lot of surgeons breathing more in the upper respiratory, like the upper chest, kind of, using all of those accessory
Mhm.
muscles. The one thing that I always teach, especially with my pelvic floor patients, is how to breathe. And
Yeah.
because of the diaphragm of the respiratory diaphragm and the pelvic floor diaphragm, they need to work together. And if we're only chest breathing because of just the high, your sympathetic nervous system doesn't know how to settle down, just finding time to just breathe is probably one of the best things you can do to help support your pelvic floor, but also just your overall well-being, no matter who you are as a surgeon.
Well said. Well said. I think I've learned so many new things today, including the fact that the core aren't just, I'm a general surgeon trained. I'm like, oh, it's the three abdominal muscles. Well, no, the core is always also the pelvic floor, and
Mhm.
how everyone needs to pay attention to the pelvic floor, not just
Mhm.
women and certainly not just pregnant women. So thank you for all those gems of information. And I think our time today is up. And as I wrap up, I really, really want to express my heartfelt thanks for you having made time to come chat with me today and be one of the, I should say, handful of inaugural guests for this podcast. So I'm sure there are going to be lots of subscriptions after this. So thank you very much again, once again, Pam, and for your time and your expertise and for being so deeply invested and passionate about the well-being of all of us working in the OR and procedural suites. So thank you very much
Oh,
again. Be
thank you,
well,
Gita.
everyone. Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.